So we are continuing the next question, our previous year NEET PG question series. We'll start with 2024 questions. So we'll discuss cardiology questions initially. So this is an ECG question. A patient with recent myocardial infarction collapses in hospital ward. He was found unresponsive. Pulses were absent. CPR was started. ECG is as follows. What is the next appropriate step? So we have to diagnose this ECG and we have to tell what is the next step of management. So understanding this question, a patient with a history of myocardial infarction who is in the hospital ward, he collapses. So he is unresponsive, means he has lost his consciousness and pulses were absent. So this is clearly a case of cardiac arrest. Okay, it is not a live patient, he has collapsed. It's a case of cardiac arrest. Whenever it is cardiac arrest, you need not worry about ECGs because I think in our previous questions we had discussed about the different rhythms. Narrow complex rhythms and wide complex rhythms, tachycardia rhythms and bradycardia rhythms. But if it is a case of cardiac arrest, you need not worry much. In fact, anyone, even if you are not going to pursue medicine in future, you must know the 4 cardiac arrest rhythms. The 4 cardiac arrest rhythms are classified into shockable rhythms, and non-shockable rhythms. There are 2 shockable rhythms. One is a pulseless ventricular tachycardia and ventricular fibrillation or VFib. There are 2 non-shockable rhythms. They are asystole. Other one is pulseless electrical activity. We'll discuss this ECG. So when you are stuck up in an ECG in the NEET, just try to discern each of the ECG waves. So are you able to make out the P wave here? No. P wave means atrial depolarization. So when P wave is not present, the atrium is not getting depolarized. So the rhythm does not originate above the ventricle or it does not originate from the atrium. So there is no atrial depolarization as there is no P wave. We are able to see only one wave, right? There is only one wave here and this is definitely a wide. One of our cases we discussed, when the wave is wide means it is more than 3 small squares. So if we start from here also, this is about 3 to 4 small squares, right? This entire wave. So definitely this is a wide complex and this is tachycardia, right? The number of number of large squares between 2 R waves is around 1 or 2. So you know the formula. The heart rate is given by 300 divided by the number of big squares between 2 R waves. So around 2 means it comes around 150. So this is actually a wide complex tachycardia. All wide complex rhythm means they originate from the ventricle. So this is probably a ventricular tachycardia. So that is what we are able to make out from this ECG, right? It is a wide complex rhythm. There is no P wave and there is tachycardia. So this is a wide complex tachycardia, probably a ventricular tachycardia. But we already told among these 4, which does this one fit? So this is ventricular tachycardia. This is a cardiac arrest, so patient does not have pulse. So this probably will be a pulseless ventricular tachycardia. So before going to the treatment, I'll just show you the other ECGs. This is the ECG which we just saw. It's a wide complex tachycardia. This is regular rhythm. So this is a VT, ventricular tachycardia. Remember, ventricular tachycardia can occur both in an alive person as well as during a cardiac arrest. During cardiac arrest, there will not be pulse. So the VT occurring in cardiac arrest patient is called as pulseless ventricular tachycardia. In alive case, it's simply called as ventricular tachycardia. There are furthermore classifications of ventricular tachycardia. We won't discuss this. So what about the second ECG? The second ECG, also there is tachycardia. Heart rate is around 150 per minute. So this is definitely tachy. Is this narrow complex or wide complex? This is also wide complex. So this is also wide complex tachycardia. This is somewhat irregular. But one striking difference between first ECG and second ECG is, see, the morphology of every wave is similar. Right? It is the morphology of every wave is similar in the first ECG, whereas here one wave is small, one is large. See, it comes like this: few are small, few are large. So this is called as polymorphic ventricular tachycardia. Polymorphic VT. The first one we can call it as a monomorphic VT. Even if you don't remember monomorphic VT, try to remember polymorphic VT, very important, because polymorphic VT is also called as torsades de pointes, TDP. One important cause of torsades de pointes is any condition causing QT prolongation. Any condition causing QT prolongation. It may be due to many reasons. There are some syndromes called as congenital long QT syndrome. So congenital reasons may be there. There are some drugs, example fluoroquinolones, antimalarials, antipsychotic drugs. They can prolong QT interval. Then some electrolytes. Example, hypocalcemia, hypomagnesemia. So there are still many more causes, but please remember there are congenital causes of QT prolongation. Some drugs can cause QT prolongation. Some electrolyte abnormalities can cause QT prolongation. Until torsades de pointes develops, patient will be stable. But once they develop torsades de pointes, it is a wide complex unstable tachycardia. So here magnesium has to be given. Please remember. Okay, so monomorphic VT and polymorphic VT. Polymorphic VT may or may not be a cardiac arrest rhythm. Okay. Now what is this ECG? We can see few white complexes. We cannot see any definite wave. But this is very, very irregular. Anything which is irregular is called as fibrillation. But in atrial fibrillation, we can make out Q waves. We can make out QRS complexes. But here we are not even able to make out QRS complexes. So this is a ventricular fibrillation. So these three are ventricular based rhythms. We have ventricular tachycardia and ventricular fibrillation. In the setting of cardiac arrest, there will not be pulse. So VT is called as pulseless VT. VFib will not have a pulse. These two are called as shockable rhythms, cardiac arrest rhythms. So basically, patient goes for a cardiac arrest, you are seeing the ECG. If you are seeing white complex, it is shockable. You have to give a shock. Whereas, see these two ECGs. There is no wave, so this is called as asystole. What about this ECG? This may look normal. The ECG looks normal, but I told you this is an ECG taken in the setting of a cardiac arrest. So patient does not have a pulse. So patient does not have a pulse, but if you are seeing the ECG monitor, patient is having a normal ECG, then also it's a cardiac arrest rhythm. It is called as pulseless electrical activity. Right? So asystole and pulseless electrical activity, these are called as non-shockable rhythms. Which means there is no role of giving a shock. Only CPR and adrenaline or epinephrine is the treatment of choice here. Whereas in shockable rhythm, we have an additional step, that is giving shock. Now when knowing about the term shock, Please remember, in your questions you may get confused between DC shock, that is DC is DC cardioversion, or simply the term cardioversion. Whereas another term is there, which is defibrillation. Cardioversion and defibrillation. There's a device, right? Implantable cardioverter and defibrillator. Cardioversion, just remember here patient is stable. Even though they have some arrhythmias, patient is stable, means they are not going in for arrest or they don't have hypotension. Then it is called as DC shock or cardioversion. When the same shock is delivered in an unconscious patient or a cardiac arrest patient or in a very sick patient, we use the term defibrillation. The shock, the joules delivered is different. Okay. So we'll read the options here. So definitely it's a white complex tachycardia. It's a pulseless monomorphic VT. What is the next appropriate step? Whether you will give defibrillator. Yeah, definitely, because it's shockable. Patient is in cardiac arrest, so defibrillation is the answer. You will check the pulse and perform CPR. I think this order is not right, because in your resuscitation, in your adult cardiology life support, once you give shock, the next time you must do is to start CPR immediately. You must not wait and see the pulse. Okay, because cardiac arrest is both the mechanical as well as electrical activity. Electrical activity stops, heart does not pump. On giving defibrillation, we are bringing back the normal electrical rhythm, but still the mechanical activity will not be present. So there is no point in checking pulse. So immediately after defibrillating, even though the rhythm comes, you must perform CPR immediately, and then only you should check for the pulse. Cardioversion may not be the answer. Just now we discussed. Because cardioversion is a shock given in a stable patient, defibrillation is the shock given in an unstable patient. Option C, defibrillator. Yeah, definitely. Perform CPR. That's what we told. Give the shock, start CPR immediately, and then only you should check pulse. So C seems appropriate. D is administer epinephrine. Of course, this is also a step in your adult cardiac life support. Shock, CPR, giving adrenaline. That's how the sequence goes. But the question is, what is the next appropriate step? So C is more appropriate than D. Because once you recognize a shockable rhythm, first thing which we have to do is to give shock. Okay. So we just discussed about some basic ECG interpretation, cardiac arrest rhythms, about polymorphic VT, and the treatment here. Continuing with your previous year NEET question. So another 2024 question on cardiology. It's a dyslipidemia question. A patient with multiple tendon xanthomas has serum cholesterol of 404 milligrams per deciliter. His LDL is 230 milligrams per deciliter. What is the most likely defect? So you can find the answer from many of the clues here. Tendon xanthomas. You would have heard about the classification of familial hyperlipidemias. So lipids are of various types: VLDL, LDL, IDL, HDL, and triglycerides. So if it is high, if any of these variant is high, it is called as familial hyperlipidemias. In that, based on the clinical clue, based on the genes, based on the type of lipid which is high, it is of 5 different types. Fredrickson's classification. So we have tendon xanthomas is very, very typical of familial hypercholesterolemia. So this again has been asked multiple times from different subjects. If tendon xanthoma is present, the diagnosis is invariably familial hypercholesterolemia. And the mutation for familial hypercholesterolemia is LDL receptor. There are many variations, or there are many mutations causing it. The most common mutation is LDL receptor, or the downstream signaling molecules of LDL receptor. So one best answer is LDL receptor. It's like an one-liner. Suppose if this tendon xanthoma is not given, they are only giving the value of LDL. Remember, I told you 5 different types of hyperlipidemia. In that, familial hypercholesterolemia is type 2, and in that LDL is high. Okay, I'll show you the chart shortly. So if the word tendon xanthoma is there, the diagnosis is familial hypercholesterolemia. If the word LDL is high is there, the diagnosis is familial hypercholesterolemia. It is of two types, heterozygous and homozygous. We are not going into the details. So considering this as a one-liner, the answer is LDL receptor defect. We'll see the other dyslipidemias. So this classification is called Fredrickson's classification. Fredrickson's classification. So we have 1, 2, 3, 4, 5. 2 is of two types, 2A and 2B. So we'll go one by one. One is called as hypertriglyceridemia. 2 is familial hypercholesterolemia. 2B is combined hyperlipidemia. 3 is called as apolipoproteinemia or remnant hyperlipidemia. 4 is again hypertriglyceridemia. 5 is again hypertriglyceridemia. Remember, one they are given here it as dietary hypertriglyceridemia. The dietary triglyceride is actually chylomicrons. So type 1 is also called hyperchylomicronemia. Hyperchylomicronemia. Remember, chylomicrons are triglycerides from the diet. So what is the mutation here is lipoprotein lipase. So type 1, elevated chylomicrons, lipoprotein lipase. 2A is the one which we have discussed just now, the familial hypercholesterolemia. What is elevated? LDL is elevated. What is the mutation? LDL receptor. Okay. 2B is combined hyperlipidemia. LDL, VLDL, everything is elevated. It's not very important for MCQs. Type 3 is also called as apo-beta lipoproteinemia. Okay. It is due to mutation in apolipoprotein. Here again, IDL is very high. Okay. Type 4 and type 5 are again hypertriglyceridemias, and the mutation is different. So for your exam purposes, type 1 is important because it is hyperchylomicronemia. The mutation is lipoprotein lipase. Type 2A is important because it is the classical familial hypercholesterolemia. The defect is in LDL receptor. Type 3, familial hyperlipoproteinemia type 3 is important. Here there is elevated IDL. Type 4 and type 5 there will be elevated triglycerides. Now since image based questions are there, I'll show images of few terms. I just told in familial hypercholesterolemia or type 2A familial hyperlipidemia, this is what occurs. In Achilles tendon, we commonly get fat deposit. It is called as tendon xanthoma. Tendon xanthoma is also the clinical finding in another disease called as primary biliary cirrhosis. So in these two diseases, we get tendon xanthomas. So tendon xanthoma is due to increased LDL, if you remember, right? You can correlate with the clues. This is elbow joint. You can see multiple small eruptions. This is called as eruptive xanthoma. So where does eruptive xanthoma occurs? Eruptive xanthoma occurs in conditions where triglyceride or chylomicron is high. Triglyceride is high in type 4 and type 5 hyperlipidemia. Chylomicron is high in type 1 hyperlipidemia. Remember, chylomicron is nothing but dietary triglyceride. Chylomicron is dietary triglyceride. Here you can see eruption is in the palm. So this is palmar xanthoma. Palmar xanthoma, this is also a very important one-liner. It's a typical feature of type 3 hyperlipidemia or familial A-beta lipoproteinemia. Okay. This is also a summary slide. Type 1 is familial hyperchylomicronemia. Chylomicrons are high. It's due to lipoprotein lipase. Type 2A is familial hypercholesterolemia. LDL is high. Here we get tendon xanthomas. So type 4 and type 5, triglycerides are high. So it is familial hyperlipidemia, familial mixed hyperlipidemia. Type 3 is familial dysbeta lipoproteinemia. Here IDL is high, intermediate density lipoprotein is high. Clinical clue, in familial hyperchylomicronemia there will be eruptive xanthoma. Type 4, type 5 hyperlipidemia also there will be eruptive xanthoma. So any condition where triglyceride is high, there will be eruptive xanthoma. Our famous familial hypercholesterolemia, there will be tendon xanthoma. In type 3 or familial dysbeta lipoproteinemia, there will be Palmar xanthoma. So let this be a revision slide. Suppose if image they give this one, this is called as xanthelasma. This is not very typical of a particular type. This occurs commonly in hyperlipidemia, any type. The composition varies. This actually has bile esters. Right, so so we'll discuss the other options. So from this question, tendon xanthoma, very high LDL, it is familial hypercholesterolemia type 2A, LDL receptor defect. Now lipoprotein lipase, as we discussed, it is type 1 hyperlipidemia or familial hyperchylomicronemia. Here there will be eruptive xanthoma. Defective ApoB100. So A-beta lipoproteinemia, right? Familial dysbeta lipoproteinemia or A-beta lipoproteinemia. This is rare one. Here IDL is high. Here we get Palmar xanthoma. So one revision slide can give you many questions. PCSK9 gain of function mutation. Since this is a one-liner, you can leave off this option, but PCSK9 being very important, I'll just tell you a brief description about PCSK9. Don't worry about the full form. PCSK9 is a protein which degrades LDL receptors in the liver. What is the function of LDL? It collects the LDL from the blood and deposits it in the liver. So when PCSK9 activity is more, or when there is gain of function mutation of PCSK9, or when PCSK9 is increased, what happens? LDL receptors reduce in number. So excess LDL cannot enter the liver from the blood. So excess LDL stays in blood and it increases blood LDL levels. So PCSK9 gain of function mutation or increased PCSK9 activity is one reason for increased LDL. I told you there are many mutations causing familial hypercholesterolemia. So PCSK9 also could be one of them, but it is not very common. Now why this is very important? Because of therapeutic implications. We have a category of drugs called as PCSK9 inhibitors. So they are drugs, when given, they reduce degradation of LDL receptors. So LDL receptors increase. So it takes over more LDL from the peripheral blood and deposits it in liver. So PCSK9 degrades LDL receptor in liver. PCSK9 inhibitors prevent the degradation and increase LDL receptors. Hence they reduce LDL in the blood. So example for PCSK9 inhibitors are alirocumab, evolocumab. These are injections. These are injection given once every 3 months, like that. So remember, there are some injections for hyperlipidemia. The next variant of this PCSK9 inhibitor is siRNA, small inhibiting RNA of the same PCSK9. So alirocumab, evolocumab are drugs which act on the PCSK9 to inhibit it, whereas siRNA. There are some RNAs which inhibit PCSK9. Example is inclisiran. This is also very important. This is also an injection given once every 6 months. It is called as lipid vaccine. So like we give a vaccine to prevent infections, to prevent dyslipidemia, to treat dyslipidemia, we are giving this injection once every 6 months. This is the latest update. They are very costly drugs but worthy for your exams. In this slide also I had presented to you. See, that type of drug given in dyslipidemia depends on the type of lipid which is elevated, because if TGL is high, we give fibrates, fenofibrate, etc. If LDL or VLDL is high, we give statins, atorvastatin, rosuvastatin, pitavastatin, etc. The next step, when LDL is high, the next step which we give is ezetimibe. If still not controlled, the next step what we give is PCSK9 inhibitor. So some say in familiar hypercholesterolemia, you need not wait for these two steps. You can directly go to PCSK9 inhibitor or inclisiran, which is the final and effective step. We have other drugs, niacin. One question was asked about niacin in 2024 also. Okay. So this is a very important question. So we discussed many important things about it. Coming to question 9 of NEET PG 2024. 45 years old female presents with chest pain, dyspnea and syncope. Which are the following suggest aortic stenosis rather than aortic regurgitation? You need not see the first part here because the question is in the second part only. You have to find out which option suggests aortic stenosis rather than aortic regurgitation. But anyway, we'll read the question. Chest pain, dyspnea and syncope, this is the triad of aortic stenosis. And we also have a triad of aortic regurgitation, which is chest pain, dyspnea and palpitation. Syncope occurs in aortic stenosis, palpitation occurs in aortic regurgitation. So we'll just discuss pathology. I am drawing a box diagram of the heart. So this is the right atrium, right ventricle, left atrium. Maybe we'll use a different color. Right atrium, right ventricle, left atrium, left ventricle. So we know very well that deoxygenated blood from the SVC and IVC empty into the right atrium. From the right atrium, through the tricuspid valve, blood enters from the deoxygenated blood enters the right atrium to the right ventricle. From right ventricle, we have another valve, the pulmonary valve, through which blood goes from the right ventricle to the pulmonary artery. Remember, pulmonary system is a high capacitance, low resistance system, which means the total pulmonary pressure is only around 25 millimeters mercury. So blood through the pulmonary artery becomes the pulmonary capillaries, where oxygen exchange occurs in the lung, and they form 4 pulmonary veins, and the 4 pulmonary veins empty into the left atrium. From left atrium, oxygenated blood enters from left atrium to left ventricle through the mitral valve, and blood enters from the left ventricle to the aorta through the aortic valve. This is the aorta. Aorta is the, in contrast to pulmonary system, aorta is the high pressure system. So we know very well the normal aortic pressure is around 80 to 120, right? Okay. So this is how blood flow occurs. In aortic stenosis, what happens? Aortic stenosis is narrowing of aortic valve less than 2.5 centimeters square. So when aortic stenosis occurs, what happens? There will be fixed flow stenosis. that there will be flow limitation from the left ventricle to the aorta. So when blood flow to the aorta reduces, what happens? There will be syncope. So this is the reason for syncope in aortic stenosis. Now, since left ventricle is not able to pump blood into the aorta, what happens? The left ventricle will try to increase itself by causing pressure hypertrophy to force the blood into the ventricle. So there will be pressure hypertrophy. So there will be pressure hypertrophy of LV to push blood into the ventricle. Now when hypertrophy occurs, what happens? Hypertrophy is increase in size of the cell. So when the left ventricular cellular size increases, when left ventricular hypertrophy increases, the demand of oxygen increases. Whereas the blood supply remains the same, so this leads to a demand supply mismatch. So this leads to a demand supply mismatch. This demand supply mismatch leads to cardiac ischemia and chest pain. So this is the second part of the trial. So syncope, how does chest pain occur? Now, even though LV tries to hypertrophy, it cannot push every blood into the aorta through the stenosed aortic valve. So some amount of blood will go back into the left atrium by back pressure. The back pressure gets transmitted to the pulmonary vein, to the pulmonary capillaries, and pulmonary capillaries leak out, leading to pulmonary edema. So the back pressure leads to increased pulmonary capillary wedge pressure or pulmonary edema. That's the reason for breathing difficulty. So this is the pathophysiology of aortic stenosis. Now on the contrary, what happens in aortic regurgitation? So we'll draw a diagram like this again. We'll concentrate only on the left part. See, remember, stenosis, whether it is mitral stenosis or aortic stenosis, is always a systolic problem. Blood does not enter from the left ventricle to aorta during systole, whereas regurgitation is a diastolic problem. So what happens here? Normally, during left ventricular diastole, the aortic valve should close completely and it should not allow any blood flow from the aorta to the left ventricle. But in regurgitation, what happens? There is a small gap. So during diastole, the aortic valve does not close completely. So some blood from the aorta will come back into the left ventricle. This leads to increased volume of the left ventricle. So in due course, it leads to volume overload hypertrophy or volume hypertrophy. In aortic stenosis, it is pressure hypertrophy. Here it is volume hypertrophy. Whenever volume increases in any cardiac chamber, it leads to palpitation. Okay. Now, when blood from the aorta goes into the left ventricle, the aortic pressure decreases very much. We know very well that the coronary circulation or the heart gets its main supply from the coronary vessels, especially during diastole. So in diastole, since aortic blood regurgitates into the left ventricle, what happens here? The coronary pressure decreases. So there is coronary hypoperfusion, leading to cardiac ischemia and chest pain. So the chest pain in aortic stenosis is due to demand supply mismatch, whereas the chest pain in aortic regurgitation is due to coronary hypoperfusion. This process is more significant in the night. So it leads to nocturnal angina. Why in the night? Heart rate is low, diastolic time is more, so chest pain is also more. But so when left ventricle gets overloaded with the blood, the same thing occurs. The back pressure goes into the left atrium, into the pulmonary vein, and pulmonary artery, pulmonary capillary pressure increases leading to pulmonary edema. So this leads to breathing difficulty. So this is the triad of aortic regurgitation. So we will read the options here. Aortic stenosis causes reduced pressure on the aortic valve. No. Aortic stenosis, left ventricular pressure is so high due to pressure hypertrophy, it causes increased pressure on the aortic valve. So this is the wrong option. So increase in myocardial oxygen consumption is seen with pressure overload than with volume overload. Yeah, correct. This is what we had discussed. The ischemia in or chest pain in aortic stenosis is due to demand supply mismatch, whereas in aortic regurgitation is due to coronary hypoperfusion. So this is the right answer. Workload has nothing to do with myocardial oxygen consumption. Wrong. We know the Laplace's law. Wall tension is directly proportional to the pressure. So more pressure, more workload, more oxygen consumption, right? So increase in preload more than afterload. It is actually the reverse. Because in aortic stenosis, afterload is high because there is a stenosed aortic valve. Left ventricle is pumping more to push blood against the stenosed ventricle. So afterload is more in aortic stenosis. Whereas preload is more in aortic regurgitation because at the end of diastole, left ventricular volume is so high. So whatever blood is accumulated from the aorta into the left ventricle during diastole, during the next systole, the left ventricle has to pump the same extra amount of blood into the aorta again. So heart is preloaded in aortic regurgitation, whereas the afterload is more in aortic stenosis. Okay. So this question can come in physiology also, but if you discuss it here, it may be useful. So you should also know about mitral stenosis and mitral regurgitation, right? In mitral stenosis, left atrial enlargement will occur because the left atrium will try to pump blood into the left ventricle against the stenosed mitral valve. What happens in mitral regurgitation? During diastole, atrial diastole, blood from the left ventricle goes back into the left atrium because of incompetent mitral valve. So left atrium gets distended, but during the next systole, the entire left atrial blood comes back into the left ventricle. So actually, if some question comes, LV is actually loaded in mitral regurgitation. It is not LA because left atrial volume is low. So even though there is a backflow, it will come back again into the left ventricle during the next systole. So left ventricle is loaded both in ER as well as MR. Okay, this completes this question. Coming to question 20 of previous year NEET PG 2024. A 26 years old male dies suddenly during exercise. History of similar death in a sibling. On autopsy, asymmetrical septal hypertrophy was present. What's the probable cause of death in this patient? So a young male, probably he may have no comorbids, he dies suddenly during exercise. So it is a case of sudden cardiac death during exercise. Okay, this clue is very important. Sudden cardiac death during exercise in a young male with no comorbidities, with a family history. There are only few reasons. So they are given the next clue. There is asymmetrical septal hypertrophy was present. Even if you don't know the actual answer, the word hypertrophy is there. HCM is hypertrophic cardiomyopathy. So this is maybe the answer. Okay. DCM is dilated cardiomyopathy. It leads to chronic heart failure, but sudden cardiac death is less likely. It can be genetic. Restrictive cardiomyopathy we will not discuss here. Ischemic cardiomyopathy is a subset of dilated cardiomyopathy. It occurs in elders due to chronic ischemia of the heart or coronary artery disease. So remember, hypertrophy of the heart occurs in many conditions. Like in the previous question we discussed, in aortic stenosis, pressure hypertrophy occurs. In hypertension also due to afterload, the left ventricle has to pump against the increased pressure of the aorta. So there will be hypertrophy in aortic stenosis also. But what is the difference between hypertrophy in AS and hypertension versus of hypertrophic cardiomyopathy? In AS and hypertension, the hypertrophy occurs in the septum and the ventricular wall equally. Septal and ventricular hypertrophy both occur equal. Whereas in HOCM there is something called ASH, asymmetrical septal hypertrophy. If you see the echo, the left ventricular wall will not be hypertrophied much, but the septum will be hypertrophied much. You can see videos, you can see images also, because this may come as an image based question or video based question. One another echo finding in HOCM is something called systolic anterior movement of mitral valve. So these two findings can be appreciated in echo. In further videos, if possible, I will show you the echo video. Okay. So asymmetrical septal hypertrophy and systolic anterior movement of mitral valve are two peculiar features in HOCM. Even though this question is easy, I brought this question to show you this one. These are some diseases causing sudden cardiac death: HOCM, long QT syndrome 1, long QT syndrome 2, long QT syndrome 3, and Brugada syndrome. HOCM is a structural disease where I told you there will be asymmetrical septal hypertrophy of the heart and systolic anterior movement of mitral valve. Whereas this LQTS 1, 2, 3 and Brugada syndrome, these are called channelopathies. So when channels become abnormal, arrhythmias occur. So in HOCM, the trigger for sudden cardiac death is exercise. In LQTS1, the trigger for sudden cardiac death is again exercise. LQTS1, 2, remember it is emotional stress. So this can come as a question. LQTS3, death occurs during sleep. This is also an important question. And Brugada syndrome also, some drugs or alcohol is the trigger for death. So this also can be a question. LQTS1 is a potassium channelopathy. LQTS2 is also a potassium channelopathy, whereas Brugada and LQTS3 both are sodium channelopathies. Okay. Coming to question 21 of previous year NEET question 2024. This is also a cardiology question. So the question is, we'll read from the last line. What's the best management in this patient? So a patient presents with sudden shortness of breath. He gets admitted in the ICU. His vitals are as follows. BP was not recordable, so there is hypotension. Pulse was 125 per minute, tachycardia. On auscultation, breath sounds were normal, cardiac sounds were difficult to appreciate. So it's distant heart sounds, we can tell. Okay, and they are given a very straightforward clue. Echo shows diastolic collapse of ventricle. Remember, only one condition causes diastolic collapse of ventricle, which is cardiac tamponade. Cardiac tamponade is sudden accumulation of fluid or blood around the pericardial cavity, which compresses upon the ventricles. So ventricles don't get filled, so there will not be any pumping of blood. Okay, so for this question, there are only two conditions which cause the triad of hypotension, distant heart sounds, and elevated JVP. Okay, here they didn't give the clue elevated JVP, but actually there is elevated JVP in this condition. So the two conditions which cause hypotension, distant or difficult to appreciate heart sounds, and elevated JVP are tension pneumothorax. Remember, it is not plain pneumothorax, it is tension pneumothorax. Tension pneumothorax is accumulation of air in the pleural cavity which compresses upon the lung. Tension pneumothorax, they accumulate suddenly by one-way valve mechanism, which means even though air accumulates in the pleural cavity, there is no way for them to go out back into the lungs. So they keep on expanding, they compress the lung, they compress the heart. So when they compress the heart, we will not hear cardiac sounds, JVP will be elevated, and the blood will not be going out from the heart because heart gets compressed. The next condition causing the same is cardiac tamponade. Here again the same mechanism. There is fluid around the heart, it's compressing the heart, so JVP becomes distended. The blood will not be pumped out because of the compression of the heart, and since there is fluid around the heart, we cannot hear the heart sounds. So there will be distant heart sounds in this condition also, right? So here they are given straight away the clue. There is diastolic collapse of the ventricle and breath sounds are normal. So this is straight away case of cardiac tamponade. Emergency treatment of cardiac tamponade is pericardiocentesis. We cannot start diuretics because BP is low. Intra-aortic balloon pump is a treatment for advanced treatment for cardiogenic shock. But here the shock is due to accumulation of fluid. So it's just removing the fluid is the option. Ventricular assist device is an advanced treatment for left ventricular failure or heart failure. Okay, it doesn't come here. Why I chose this question even though it is straightforward is this difference is a very important concept which you have to remember. These are two pericardial diseases which you must remember. One is constrictive pericarditis and cardiac tamponade. Some 1 or 2 questions that come from this one concept alone. Okay, including the pathophysiology. So we'll just go through it quickly. Constrictive pericarditis is a chronic condition. There is some insult or injury to the pericardium. They get fibrosed, they become thick, they constrict and they compress upon the heart. So it is a chronic condition. Whereas cardiac tamponade is an emergency. So it is acute accumulation of blood or fluid around the pericardial cavity, compressing or collapsing the lungs, collapsing the heart. So that's what we get. Diastolic collapse of ventricles is one of the echo findings here. What may be the echo finding in constrictive pericarditis? Thick or calcified pericardium. Okay. So constrictive pericarditis being chronic, there will be calcified pericardium. Cardiac tamponade is an acute, there will be diastolic collapse of ventricles in echo. Now since the heart is getting compressed in both these conditions, JVP will be elevated. Okay. But how to differentiate the JVP of both these conditions is by the waves. So I am not going to discuss the pathogenesis, how the waves form, but just remember a mnemonic here, PYTAX. In constrictive pericarditis, Y descent and X descent both are prominent. Okay. In tamponade, take the TA together. In tamponade, only X descent is prominent. Okay. In constrictive pericarditis, Y descent and X descent both are prominent. In tamponade, only X descent is prominent. So what is the opposite of prominent? X descent is prominent. In tamponade, Y descent is absent here. So if you remember physiology, Y descent is the wave which occurs due to the last filling of the ventricle, filling of the atria. The atrial filling does not occur in tamponade. So even if you don't remember that fact, remember the mnemonic PYTAX. So both X descent and Y descent are prominent in pericarditis, whereas only X descent is prominent in tamponade, Y descent is absent. Remember this. This was asked in the 2024 NEET. So why Y descent is absent? Because the last stage filling of the atrium is absent. So what about Kussmaul sign? Kussmaul sign is normally during inspiration JVP falls, but Kussmaul sign is paradoxical rise in JVP during inspiration. It is typical of constrictive pericarditis because the pericardium cannot give way. So during inspiration, even though because of negative intrathoracic pressure, blood is drawn into the SVC and IVC, it cannot enter the right atrium. So Kussmaul sign is present in constrictive pericarditis, whereas it is absent in tamponade. Pulsus paradoxus is a very specific finding. It is present in cardiac tamponade. Remember, pulsus paradoxus is a paradoxical fall in BP more than 20 millimeters of mercury during inspiration. It is not a pulse finding. It is a BP drop during inspiration. It is typical of cardiac tamponade. Remember this also. What auscultation finding do we get in consecutive pericarditis? We get pericardial knock. Whereas, as discussed in cardiac tamponade, we will not hear breath sound. We will not hear cardiac sounds. Since pericardium is thick in consecutive pericarditis, it is treated by stripping. Treatment of cardiac tamponade is pericardiocentesis. So just remember this. Consecutive pericarditis is chronic, cardiac tamponade is acute. In both consecutive pericarditis and cardiac tamponade, JVP will be elevated. In consecutive pericarditis, both X descent and Y descent are prominent. In cardiac tamponade, only X descent is prominent and Y descent is absent. Kussmaul sign is present in consecutive pericarditis and absent in tamponade. Pulsus paradoxus is absent in pericarditis but present in tamponade. Pericardial knock is the auscultatory finding in pericarditis. In tamponade, there will be absent heart sounds. We have to treat pericarditis by stripping. We have to treat cardiac tamponade by pericardiocentesis. Okay.